Welcome to QD Clinic. Hi, I'm Dr. Jack Cush with Room Now. This QD Clinic is devoted to a replay of Room Now Live 2023, where we're going to ask and answer questions from the pod on psoriatic arthritis. The pod or session was called Modern Management of Psoriatic Arthritis. It featured three excellent speakers, Dr. Laura Coates talking about remission in psoriatic arthritis, Dr. Eric Ruderman talking about JAK inhibitors in psoriasis and psoriatic arthritis, and lastly, Dr. Christina Chambers talking about pregnancy in PsA. Again, at Room Now Live, we answer your questions either during the meeting or, in this case, after the meeting on QD Clinic. We'd like to thank the sponsor of this week's replay of psoriatic arthritis, AbbVie, for supporting rheumatology education. So let's get into it. We have questions on remission, on JAKs, and on pregnancy, and then a whole bunch of other PsA-related questions. Dr. David Morales asked, do you think that the clinical trials improvement levels formulated by the ACR had to change in order to translate their benefits to patients? If I understand the question, I think what he's asking is, are the measures that are used in clinical trials and that are used to define remission, are they clinically important to you in practice and to your patients? And the bottom line is generally no. I mean, you don't talk ACR 20 and DAS scores with your patients. But on the other hand, some of the measures used in especially psoriasis, and particularly the minimal disease activity measure that's very popular, is something that you do in your practice all the time. And it is an achievable goal. So I think that there has been a move towards using measures and outcomes that are actually applicable to practice. What is the role of comorbidities when you don't achieve remission? Asked Dr. Morales as well. And the point is that not addressed in this lecture, but we have put up a number of news items and featured articles about the role of comorbidities. Patients with comorbidities, patients with dactylitis, patients with enthesitis have worse disease in psoriatic arthritis and are more difficult to get into remission. It is a marker. Jasleen Kaur asks, a patient with lymphoma in remission with severe psoriasis, but still has a very high PsA and high joint activity. Which biologic or DMARD would you consider favorable? So again, basically it's very active skin and joint psoriatic disease, right? And you're being hampered by the risk of lymphoma. Well, I'd use any drug I wanted to use. I would use TNF inhibitors. I'm not afraid to use them. I think the argument is that TNF inhibitors don't cause lymphoma, but we could have that argument. But you've got lots of choices here to control psoriatic disease overall with IL-17, IL-23, JAK inhibitors, other biologics. You've got a lot of choices. I don't think it really matters which one you use. My answer to the question is use the most effective drug that's in your arsenal. April Woodrow asks, what should you use for nail psoriasis and what's the data? I think all the drugs that have been shown to be effective in psoriasis have been shown to be effective at nail psoriasis. I think that the IL-17 and 23s and dual inhibitor, 12-23 inhibitor works really well at nails, but TNF inhibitors work very, very well as well. Later on, there's a question about palmopustular psoriasis and what works best there. Palmopustular disease or pustular psoriasis is very difficult to manage, no matter what therapy you're using. The unofficial word in that we heard last year at Room Now Live from Dr. Ken Gordon, and what I've been hearing based on early research is that JAK inhibitors seem to work very well in patients with, again, pustular psoriasis, palmopustular disease. Rina Modha asked, what's the best therapeutics for dactylitis? And they all are equally effective. And we had Artie Kavanaugh review that. You should look at the video that from Dr. Kavanaugh on either Room Now under the video section or on our Room Now YouTube channel, and look up Dr. Arthur Cavanaugh. He's got a lecture on treatment of dactylitis, and he shows you that they're all about the same, but they're all not. We don't have any one biologic or DMARD that has a killer great response in dactylitis. So it is still trial and error. Moving on to JAK inhibitors, Sri Koniu asks, with regard to the JAK inhibitors, is a zoster vaccine optional for patients who never had chickenpox or who were vaccinated against chickenpox? I think if you had or didn't have chickenpox or were vaccinated against chickenpox, I think when you go on a JAK inhibitor, you still need to receive the zoster vaccine. There are many cases of patients, and you're never really sure about how immunized an actual infection or even an immunization that was given many, many years ago, how effective that is current day. So, and which is why, when we show that the new Shingrix vaccine, the subunit inactive virus vaccine, we show greater than 90% protection with that. But that's only for about 4 years. We need longer ongoing studies to prove its long-term effect, and often there is a waning of effect. So my answer is, yeah, I would still use the subunit vaccine in someone going on a JAK inhibitor. Ramahi asks, would you avoid a JAK inhibitor in a 50 to 60-year-old with a family history of early onset CAD? I'm a big believer, actually I should say I'm a big disbeliever in the value of family history. It means absolutely nothing to me unless we're talking about a few things. And in this case, I think Maral is asking about someone who died of a heart attack, before age 45. That is often inherited, and that is a little worrisome. And we're talking about, the risk factors for getting a JAK inhibitor is over 65, smoker, history of cardiovascular disease. If this person had a strong family history where someone died before age 45 and they're not elderly, they're still 45 to 60, I might be concerned and I might use another drug. I would definitely be concerned if they were also a smoker. Okay? I would definitely be concerned if they had no cardiac history of their own, but had a strong family history before age 45. That's what's inherited. And they were over 65, again, I would avoid the JAK inhibitor. That's my rules for, and everyone's rules these days that understands the data from the oral surveillance study is you don't give JAK inhibitors first, you give a TNF inhibitor first, and then you never use a JAK inhibitor, consider a JAK inhibitor over age 65, smoker, prior MI, strong cardiovascular history. That's a population you don't want to use it in. Also, someone who's had a prior VTE, we're going to get to that in a second. Another question talks about carotid plaque and carotid ultrasound. If that was found, would you change the JAK inhib? Again, that's kind of tempting, but that's not really who was included in the oral surveillance study with tofacitinib done by Pfizer. Again, remember who was included. People with high-risk cardiovascular disease. That did not include carotid plaque on ultrasound. So that would not be an exclusion for me. Would I worry a little bit? Maybe a little bit, but honestly, it wouldn't hold me back. I'd go for the things I just talked about. Marilyn Solsky asked, what's the comfort level in starting a JAK in a patient who's taking an anticoagulant for prior history of PE or DVT? If you had a DVT or a PE, you're likely to get it again. And my goodness, if you go on a JAK inhibitor, you're really likely to get it again. So no, people with VTEs, PEs, DVTs, you don't need to start them on a JAK inhibitor. Use something else. Since all these warnings came out, I've had patients who have a prior history of DVT and VTE, and we find all this information, but the patient's doing great on a JAK inhibitor for 3 years. Do I stop it and move on? My conversation, number one, I talk to the patient about it. If they only had one DVT or maybe one PE, maybe they don't have to stop. But if they've had repeated events like that, I'm urging them to stop. Again, why ask for trouble when the patient's giving you the warnings? So would you worry about using a JAK inhibitor in an elderly woman or an elderly man, and does gender add anything to the elderly issue? Elderly is a risk factor, right, for some of these JAK warnings, but gender was not. So I would not necessarily distinguish between the two. Dr. Fan in Dallas asks, what's the mechanism that JAK inhibitors work in axial disease? What's the cytokine that's being targeted? Again, cytokine effects of JAK inhibitors to me is a blur. Yeah, it affects IL-6, but a whole bunch of ones that I don't know what they mean, including IL-5. We do know that JAK inhibitors do have an effect on IL-12 and 23. And we do think that maybe, again, maybe, it is through the targeting of IL-12 and 23, but we do know that, again, that's not where ustekinumab works, which is a 12-23 inhibitor. So for Dr. Fan, I don't think we know, but there's a postulate there. Kristen Holscher asks, any thoughts on when deucravacitinib, the trade name Sotyktu, will be approved for psoriatic arthritis? It's approved for psoriasis. And my expectation is that it would be approved probably sometime this year, although I have no direct knowledge or inside track on such information. Another question is, a patient who has axial disease and psoriatic arthritis failed Cosentyx and Taltz with contraindications, TNF inhibitors, and nonsteroidals, what would you use? Well, we've heard from Philip Meese that maybe there's a role for JAK inhibitors here. And again, the IL-17s are certainly work well in axial disease patients, but IL-23 not so much. But there seems to be, in PsA with axial disease, there seems to be a signal that maybe they'll respond to JAK inhibitors. That's probably what I would consider. Vijaya Murthy asks, are the JAK inhibitors approved for non-radiographic axial SpA? No. I believe they're doing studies, but they're not yet approved for that. Moving on to pregnancy. Vishali Dalvi asks, which non-biologic DMARDs were used when comparing DMARDs to biologic outcomes in pregnancy? Well, it's probably, I don't know the answer to that question, but it's obviously not going to be the drugs that you wouldn't use during pregnancy, meaning you wouldn't use methotrexate, you wouldn't use mycophenolate, they're totally contraindicated, you wouldn't use leflunomide, so you're kind of left, anybody's taking a DMARD during pregnancy, sulfasalazine, hydroxychloroquine, azathioprine, other thiopurines, maybe cyclosporin, but it's probably hydroxychloroquine, sulfasalazine. Compared to biologics, yeah, no, of course, patients on biologics during pregnancy are going to look better than those relatively modest effect oral DMARDs. Dr. Solsky again asks, is apremilast safe during pregnancy and lactation? Again, there isn't sufficient data at this point to comment on that, and it wasn't covered by Dr. Christina Chambers. Dr. Chambers, as you know, is a worldwide leader. She used to run the Otis registry. She now runs the similar effort called Mother to Baby and other similar activities at the University of California, San Diego Medical School. She's got the best data, but she did not cover that particular information. Kristen Holscher asks, how to avoid postpartum flares in your psoriatic arthritis patients. Number one, breastfeed. As long as they're breastfeeding, low rates of flare. But as soon as you stop the breastfeeding, or if you never breastfeed, and if you don't continue the biologic, you're going to flare. You know, it's like 90% within 3 months are going to flare if they've been off of, DMARDs and or biologics throughout the pregnancy. The other way to avoid flares postpartum is to treat them throughout the pregnancy. They do it in ulcerative colitis and Crohn's disease. Look up the Piano registry study. Very safe to continue the biologic. Dr. Chambers showed data that patients who get pregnant on a biologic and stop the biologic, and therefore they're not on biologic for most of the pregnancy, compared to those who are on the biologic throughout the pregnancy, those who stayed on the biologic did better. So again, with no downside. So meaning no fetal malformation risk, very little in the way of preterm births or preeclampsia. Okay. Other questions unrelated to the talks and the topics of the talks, but related to psoriasis. Christian DeQuet asks, we've not heard about the microbiome and fecal transplants, not covered, but was covered last year in ACR and EULAR meetings showing that fecal transplants didn't work in psoriatic arthritis. More on that to follow, I would assume. Would I use an IL-17 inhibitor in a psoriatic arthritis patient with COPD? Certainly. There's no contraindication there. To use Otezla in psoriatic arthritis patients with a high infection risk? Well, why would a psoriatic arthritis patient have a high infectious risk? Otezla is a perfectly safe drug. No greater risk of SIEs, but do you think Otezla is a strong enough drug for someone with very active psoriatic arthritis that's driving the high infectious risk? Or are there other factors involved here? So it may be the safest drug. It may not be the most effective drug. While many of you believe that Otezla is a drug for mild psoriatic arthritis, I don't believe that at all. I believe psoriatic arthritis works in a minority of people, including people with mild disease, moderate disease, and really severe disease. I've done Otezla trials, and I've seen patients with, 14 swollen joints go into remission on Otezla. It just happens to work in a minority of people. So you'd like to see it work in 50, 60% of people, ACR 20 responses, but it really only works in about 40%. That's why it gets the mild label. It's sort of like a mild response. It has nothing to do with disease severity. What's my go-to for axial therapy? My go-to is still TNF inhibitors. You can look at a lot of other things. Dr. Bob Jenkins in Dallas asks, are you concerned about treat-to-target guidelines that can be used by pharmacy benefit managers to force discontinuation of drugs? Well, Dr. Jenkins and I practice in the state of Texas, and I can see PBMs trying to stop. Let's say someone's taking a perfectly effective drug. I'm just going to say a TNF inhibitor for let's say a JAK inhibitor for psoriatic arthritis. And they've been on it for 3 years. But because of the way the guidelines are written, GRAPPA guidelines or EULAR guidelines, they'll come around and say, well, you got to change that per the guidelines and use something that's before it, something that they're going to save money on. In the state of Texas, you can sue, if you're a patient, you can sue your insurance company for malpractice. I would say stopping a drug that's perfectly effective to start a drug that you don't know is going to be effective, yeah, that's malpractice in my book. And that's the letter I'd write in protest. And I would back it up with literature and whatnot. These are difficult issues, and the PBMs will do anything to save money at your patient's expense. Shame on them for that kind of nonsense. Saad Akba Kale asks, in patients who have psoriatic arthritis, but they also have HIV, do I favor any biologic? No. Actually, I've used all of them, including especially TNF inhibitors. I've used all the TNF inhibitors. I've used apremilast, and I've used IL-17 inhibitors. I haven't used some of the newer drugs in HIV patients, but there's no downside to doing that. Of course, you follow lymphocyte counts and CD4 counts if you think that that's an issue. And I assume your HIV patients are on HRT therapy. Justine Kaur asks about multimorbidity in psoriatic arthritis. Yeah, it's a big problem. But whose responsibility is it? The rheumatologists or the PCPs? All of you rheumatologists are saying it's the PCP's job to manage the diabetes and, the bed sores and the vaccinations and, their angina, etc. The problem is patients who, like you, think that you're the best doctor and they're only going to see you and they figure you're going to manage all that stuff, even though you tell them you got to go to a primary care doctor. My strategy on this is the risks, the role of comorbidity and how damaging it is, especially in psoriatic arthritis. You identify the comorbidity, you start treatment for the comorbidity, and if you want to refer either to the PCP or specialist, go ahead and do it. But until they take over the patient, it's your responsibility. But it's your responsibility to identify the problem and start the treatment. That's how I handle it. Our last question is in patients with psoriasis and joint pain, but no swollen joints or signs of inflammation, how do you manage the pain? What do you do? Would you do imaging? And I think that's actually a really good situation. First off, psoriasis and joint pain, I get those consults all the time, and 70% of them are fibromyalgia, 20% are osteoarthritis, 5% are overuse syndromes, and rarely is it like some occult synovitis some PsA wannabe condition that is yet to reveal itself. But so again, diagnosing the OA and the PsA and the overuse syndrome, repetitive strain syndrome, is easy for you, the rheumatologist, and I wouldn't need imaging. But if I didn't have a clue based on my exam and history, yeah, I would do ultrasound, looking for enthesitis or synovitis, and I haven't done it yet, but I might consider an MRI in such cases. Anyway, check out the content this week on both the website and our YouTube channel. We got a lot of videos from these 3 lectures. We got a great Q&A session, a panel discussion with Drs. Coates, Ruderman, and Chambers that you should also take a good look at. And then next week, we're going to have a Tuesday night rheumatology session on vasculitis. 3 powerhouse speakers, Dr. Carol Langford, Dr. Anisha Dua, and Dr. Robert Spira, talking about GCA, PMR, and GPA. We're going to show some of their presentation, take your questions. That's Tuesday Night Rheumatology. You can sign up with the email that's being sent to you. And also that content, the individual lectures, the panel discussion, and questions from that session will all appear next week on the website. Tune in for more. Room Now. Enjoy.